Oroantral communication and oroantral fistula. Oroantral communication is an unnatural communication between the oral cavity and the maxillary sinus. Causes of oroantral communication, oroantral fistula, extraction of upper molar and premolar teeth, tuberosity fracture, dentoalveolar periapical infections of molars, implant dislodgement into maxillary sinus, trauma 7.5%, presence of maxillary cyst or tumors 18.5%, osteoradionecrosis, flap necrosis, dehiscence following implant failure as a complication of the Cardwell-Luke procedure. Predictive factors or the predisposing factors. Proximity of sinus flow, tuberosity, thickened tooth cement, tooth fused to jawbone, that is ankylosis, infected teeth, long-standing decay, marked periodontitis, gum disease, long-standing previous history of oroantral communication. Treatment of oroantral communication, less than or equal to 2 mm, non-invasive intervention, spontaneous closure by blood clot, ensure formation of clot by packing gauze pack over surgical site for 1 to 2 hours. Sinus precautions for 10 to 14 days, opening the mouth while sneezing, not sucking on straw, cigarettes, avoid nose blowing, antibiotics, penicillin, nasal decongestant, systematic decongestant or the systemic decongestant for 7 to 10 days. Follow up after 48 to 72 hours to see two things. Oroantral communication becomes evident leakage of air into mouth fluid, into nose, or symptoms of maxillary sinusitis. Sinusitis appear. Oroantral communication. If opening is of moderate size, 2 to 6 mm, measured by sizable piece of bone comes out with the tooth, place gel foam into the socket and fear of 8 suture done over tooth socket. Sinus precautions, antibiotic, penicillin, nasal decongestant, systemic decongestants for 7 to 10 days and follow-up. Oroantral communication. Sinus opening is larger, 7 mm or larger, repair with the flap procedure. Options, buccal advancement, flap, sinus precautions, and medications. Sinus precautions. Do not blow your nose for at least 2 weeks. Do not forcibly spit for 1 week. Do not smoke or use smokeless tobacco. Smoking greatly inhibits the healing process, especially into the sinuses. Sneeze with your mouth open. If the urge to sneeze arises, do not sneeze through your nose and avoid pinching nostrils. Drink without a straw for 1 week. Avoid swimming for 1 month. Strenuous exercise for 1 week. Gentle swishing with salt water may be done for 1 week, but do not rinse vigorously. Slightly bleeding from the nose is not uncommon and may occur for several days after surgery. That is, do not blow nose, do not forcibly spit, do not smoke, sneeze, drink without straw, avoid swimming, gentle swishing with salt water, and slight bleeding from the nose is not uncommon. Oroantral fistula is an epithelialized, pathological, unnatural communication between oral cavity and the maxillary sinus. It develops when the oroantral communication fails to close spontaneously, remains patent, and get epithelialized. There is migration of oral tissue into the defect. The epithelialization occurs when the perforation for the last 48 to 72 hours. Within few days, the fistula gets organized within the epithelialization of the fistula tract. Osteitis of the surrounding bony margin, presence of foreign bodies, or development of maxillary sinusitis. Spontaneous healing is hampered, which may result in chronic fistula formation. Oroantral fistula, seen after 7 to 8 days, is an average time during which oroantral perforation epithelialize and become a chronic fistula tract. Experimental studies have confirmed the clinical finding that a maxillary sinusitis is present when an untreated oroantral communication has persisted for more than 48 hours. Basic principles. There are two basic principles that must be considered while operating the oroantral fistula and the oroantral communication. The first is that the sinus must be free of any type of infection with adequate nasal drainage. The second is that the closure must be tension-free and consist of broad-based, well-vascularized, soft tissue flap over the intact bone. Successful closure of the oroantral fistula should be preceded by the complete elimination of any sinus pathology. The fistula tract, sinus infection, degenerated mucosa, and diseased bone. Chronic oroantral fistula, small opening less than 5 millimeter, management of chronic sinusitis, antral irrigation, fistulous epithelium, excision, elevation from bony wall, nasal decongestant, antibiotic, closure of small fistula with buccal palatal flap, maxillary ostium closed, nasal androstomy, follow-up for several weeks, failed healing, use alternate flap. Chronic oroantral fistula larger than 5 millimeter, management of chronic sinusitis, use of nasal decongestants, closure with buccal pad of fat, tongue, temporalis muscle flap, nasal androstomy, sinus precautions, follow-up, and failed healing. Alternate flap. This is a image where periosteum, vestibule, mucosa, palatal soft tissue, periosteum, vestibule, elevated flap, palatal soft tissue is seen. Criteria for screening the surgical approach to close oroantral fistula, location of the defect, size of the defect, height of the alveolar ridge, vestibular depth, persistence of the defect, sinus inflammation or infection, general health of the patient. Treatment modalities to repair the oroantral defects include local or free soft tissue flaps with or without autografts or allograft materials. Buccal flap is suitable for closure of small and mesial fistulas. The palatal flap is feasible option for repairing oroantral communication. More likely, more defects in the premolar area. The buccal pad of fat is also very commonly used. Types of buccal flaps for oroantral fistula closure. The procedures utilizing buccal mucoperiosteal flap for closure include straight advancement flap, rotation advancement flap, transverse flap, and sliding flap techniques. The procedures utilizing palatal mucoperiosteal flap are straight advancement flap, rotational advancement flap, hinged flap, island flap procedures. Fistula removal, excision line, fistula, extent of bony defect, transverse releasing incision, bony defect. And this is another diagram. And we again have, to conclude, we have the oroantral communication and the oroantral fistula. Oroantral communication most commonly affects in the maxillary second molar during traumatic extraction of the maxillary second molar. An anomalous communication occurs between the maxillary antrum and the oral cavity. This communication that persists over a period of 10 to 14 days, there is an epithelial tract that is formed in the tunnel that communicates between the oral cavity and the maxillary sinus, and it is called as the fistulous tract. We should take care that while surgically closing the oroantral fistula, the epithelial tract has to be removed. Otherwise, there will be gaping of tissue. Otherwise, gaping of tissue will be there. And coming to the clinical diagnostics of oroantral fistula, we will tell the patient to take colored betadine solution onto the mouth and above the head. When the water comes out through the nose, the colored liquid comes out through the nose, we know that there is an anomalous communication between the oral cavity and the maxillary sinus that has come out through the nose. Cotton wisp technique, where we pinch the nose and tell the patient to blow and keep the wisp of cotton near the socket dances. And there will be frothing of blood for the fresh oroantral communication. However, probing of a socket is not encouraged. Also, there is something called as the mouth mirror test, where we keep a mouth mirror, pinch the nose, and tell the patient to blow the nose, and the mouth mirror gets fogged. And oroantral communication and the oroantral fistula has got two kinds of surgical approaches, as we have discussed earlier. Thank you.